inshallah.
And this is your question. Yes. Right. So if you have read and understood, considering its surgical pathology station, kindly identify this image. If you can describe it, please. And what are your differential diagnosis?
Yes. So as regards this image, I see burly papule with
Yes.
central
And
ulceration
yes.
with rolled in or inverted edges with
Okay.
redness at the periphery. So my top differential diagnosis is basal cell carcinoma.
Very good. Very good. What other? Yes.
Yes.
What other conditions would you consider?
Maybe squamous cell carcinoma. The
Very
other one may be ulcerative keratocanthoma, and maybe traumatic ulcer also, but
Very good.
in the stage of healing. Yes.
Very good. Okay. Can you? People are joining. Okay. Can you please tell me how would you confirm your diagnosis?
Yes, as regard the diagnosis is confirmed by biopsy in form of brush biopsy or punch biopsy or excisional biopsy, the most important, with at least a 4 millimeter safety margin.
Yes. What
Yes.
else? When taking biopsy for this lesion, what else is more important to keep in your mind?
Yes, the first one to in clinical examination to examine the regional lymph nodes.
Very good.
And the area also supposed to be with distant metastasis, but not in basal cell carcinoma. It is liable to local growth without tendency to metastasis distance.
Distantly. Very good.
Yes.
Okay. People are involved. Okay. Can you please? What happened? Person got on. Okay. Sorry, this is disturbance. Can you please tell me how the basal cell carcinoma spreads or metastasizes? Can you tell me all the processes or the sequelae?
Yes, as regard basal cell carcinoma originate from the basal layers of the epidermis. That's usually any according to the metastasis is spread by release of vascular endothelial growth factor, which allow dilatation or expansion of the vessels, and may also this will lead to expansion of the primary tumor itself and the draining lymph node also and sentinel lymph nodes, leading to lymphatic permeation by embolization and permeation.
Okay,
And
in
also
case of
local,
yes, please. In
yes,
case of
and
yes, please.
yes,
Sorry.
local spread also by rodding.
All right, good. Thank you.
Yeah.
All right. Can you please tell me, in case of basal cell carcinoma, there is always a fear that there'll be local involvement or deep penetration of the local area. So how would you manage to prevent this deep margin involvement, or how would you manage this deep margin involvement?
But as regard avoiding deep margin involvement, I will depend on frozen section intraoperatively, and also in some aesthetic area as face, I will do what's called Mohs micrography until the deep margin is clear away from any distance, away from any malignant cells. This is how to avoid the
and what measures would you take to prevent recurrence to happen?
Yes, and also I will consider safety margin and the thickness of
Yes.
Breslow according to the lesion of the depth is about 0.76. The safety margin must be at least 1 centimeter.
Yes.
And between up to 1 millimeter, the safety margin will be at least 2 centimeter. If more than 1 millimeter, the safety margin will be at least 3 centimeter.
Very good. Okay, can you please tell me how would you differentiate basal cell carcinoma from squamous cell carcinoma? Can you mention 5 differences, please?
Yes, as regard the usually squamous cell carcinoma is usually in the area sun exposed area, mostly in the lower lip between the junction between outer third and the medial 2/3. The basal cell carcinoma is in the area above a line of the nasolabial fold and above the area was a line in tragus alignment. The squamous cell carcinoma usually from the middle layer and the superficial layers of the epidermis. Basal cell carcinoma from the basal layer. Basal cell carcinoma liable to indolent, slowly gross, ulcerate, and locally invasive, local growth without tendency and never to metastasize. Squamous cell carcinoma liable to invade the basement membrane and with local erosion and also regional to the lymph node and distant metastasis. The squamous cell carcinoma liable to develop keratin burl formation. Basal cell carcinoma is liable to demonstrate in what's we call palisade appearance in the histopathology. Yes, basal cell squamous cell carcinoma invade the basement membrane and they don't respect tissue planes. Basal cell carcinoma usually respect and local only eroding without liability of the distant.
Okay. How should a patient with basal cell carcinoma be followed up after you have performed the procedure or excision biopsy and then you have found the report and then it has been confirmed that it is basal cell carcinoma? How would you follow up the patient?
Yes, this one initially I must confirm from the histopathology that the resection margin and the deep margin is away from any malignant lesion. After that, I will counsel the patient by avoid sun exposure at any time. The second one, report ultraviolet rays, report of any lumps or bumps appearance along the course of the previous lesion or draining lymph node. I will count the patient. If we detect any lesion, must consider recurrence and attended for excision and exclude any recurrence or distant metastasis.
Very good. Okay. Can you please tell me if just suppose this patient, you took the biopsy and you sent the patient home and the patient's wound has got infected. So which organism would you suspect most commonly to be
Staph aureus?
Okay. If you have given Staph aureus is the most common organism, okay, if the wound grew up and it is not responding to any management or any treatment and it is found out to be MRCS positive, then how would you manage this patient's wound?
According to the status of the patient, if the patient developed abscess, I will go for incision and drainage.
Very good.
Then put the patient in outpatient treatment in form of vancomycin, telavancin, or daptomycin, linezolid, according to the microbiology team and the policy of the hospital. If the patient, and also there is some measures we must consider to prevent MRSA for all patients. We must wash our hands with water and soap. The second one, use of alcohol hand rub and avoid avoid interward exchange, and also the bed linings and the waste product according to the trust policy, antibiotic according to the trust policy and the microbiology team, and also decontamination considering mubricine oral and the chlorhexidine for decontamination.
Okay, very good.
Yes, according to the Yes,
please.
if the patient is single, I will put the patient in a single room. Is more than one case will be studied in cohort study. Avoid exchange, avoid overcrowding. Any reusable instrument must be disinfected and decontaminated. Put the antibiotic also according to the policy of the trust, and any waste product in the red bag and all linen in the yellow bag.
All right, good. One last question.
Yes.
You've taken the excision biopsy, and then there is a gap in the side of the nose of the patient. How would you close that gap? Would you stitch it back, or what would you do?
Can you restate the question again? I
Yes,
didn't hear.
you took the biopsy and you excised the wound. You excised the lesion.
Yes.
Now there is a gap, or there is a place with which a patient's nostrils and they are open. So how would you close that gap?
Yes, after confirmation of the free of the deep margin and sexual margin from malignancy, consider both graft or flap, or let the patient to heal with secondary intention.
Yes.
But after taking culture and sensitivity and exclude any infection. Yes, primary closure, graft, flap, or secondary intention healing.
Okay.
Yes.
Right. Thank you.
Thank you.
Bell went, and then I just wanted to ask you. Very good. I've started, and here is your question. Dr. Is Dr. Hamdi there? Yes.
Yes.
Are you reading? Okay.
Yes.
So if you have read and understood, considering it examination station, kindly begin.
Good afternoon. Hello, sir. Good afternoon. I'm Dr. Muhammad, the team doctor of today. May I confirm name and age, please?
Samantha, 40 years old.
Nice to meet you, Ms. Samantha. Today I've been asked to examine your back and your legs. This may include looking, feeling, doing some special tests. Are you okay with that?
Yes.
Okay. Do you feel any pain at the moment?
Negligible. You can go ahead. You can go ahead with the examination.
Yes. Okay. Please, can you walk a few steps for me in the room?
Okay.
Okay. Thank you. And come back again. I will look first. I will look for any abnormal gait, and look for the back for any muscle wasting, any deformity, any scoliosis, any skin changes, any scars. As in, I will
also ask to walk on the heel and then walk on the toes. Yes. Next.
Yes. Okay. And after looking, I will start feeling the patient. I feel and looking at his face for any tenderness. I will feel the spinous process, all the spinous process and paraspinal muscles. Then I will do a Schubert test.
What will be the patient's condition? Would the patient be standing or sitting or lying down? And how much exposure would you ask for? Tell me everything, please.
Yes, the patient is still standing, and
Yes.
I start feeling. After finishing of inspection, I will feel his spinous process and all the paraspinal muscles for any tenderness. Then I will ask the patient to do movement like me, forward flexion and extension,
Yes.
and lateral flexion. Then I will do before lying in the couch. I will do the Schubert test.
Yes. How would you do that? Why would
Yes.
you do that? To confirm what or to see what? Tell everything, please.
Yes, then I will do. Hello.
Yes.
Then I will do Schober test by marking on the dimples and 5 centimeter, 5 centi below and 10 centi above, and then ask the patients to lean forward. There must be more than 20. If there is if it is less than, so the patient has the patient is, there is a limited the patient has limited flexion.
Yes.
Then I will ask the patient to lie on the couch.
Yes.
And start the lower limb examination first by the tunes, by leg roll and leg lift, and then ankle clonus. Then I will examine the power of his legs by examining the hip flexion against hip, by asking the patient to push against my hand while I put my hand on his thigh, and then at the back of his thigh for the hip extension, and then by kneeling, by flexing his knee, ask the patient to push against my hand for knee extension, and at the back for knee flexion. And then for the dorsiflexion and plantar flexion against my hand, and also eversion and eversion, and a knee extension and a big toe extension.
Yes. Then
then I will examine the reflexes of the patient, the knee reflex, by hanging his knee on my hand, and then direct tapping on the patellar tendon and look for any flexion of the quadriceps, and then for the action of quadriceps, then the ankle reflex by putting his by making a four shape and slightly dorsiflexion and tapping on the tendo Achilles, and look for the gastrocnemius, and may also this reflex, and then the coordination by asking the patient to put his heel again on the knee of opposite leg, and down back on the shin of the tibia, and repeat it several times, and repeat on the other side. Then I will check for the sensation, the cotton sensation, by asking the patient to feel it in his sternum, and then close his eyes and check for all the area of the leg, and do the same for a pinprick sensation.
Good. Anything else would you do to complete your examination?
Yes, to complete my examination, I would like to complete to examine the joint above, cervical, and also the hip joint.
Yes.
That's all.
Yes. What about the femoral stretch test?
Yes. Yes. Okay. Yes. Femoral stretch.
All right. Can you present your case now, please?
Yesterday I examined this spine as a Mr. Today I examined Mrs. Smith, 40 years old, which presented with chronic low back pain, and the chronic low back pain. By inspection, there is no swelling, no tendon. There is no swelling, no muscle wasting, no scars, no any back deformity. On feeling, there is a tenderness, especially at tenderness at the lumbar lesion, at the lumbar area, and there in assessing the hair and doing neurological examination, there is weak knee, there is weak big toe extent, there is all muscles are normal except for a weak big extension, and the diminished sensation on the dorsum of the foot. So my main differential diagnosis is maybe the lumbar disc herniation,
Yes. At what level?
At L5.
Okay.
I should
What
also,
other conditions would you consider?
yes, I should also consider other causes such as functional mechanical back pain, or rheumatoid arthritis, or osteoarthritis, or septic
All right.
arthritis.
How would you confirm your diagnosis?
I will firm my diagnosis by doing a plain X-ray of the spine, AB of the lumbosacral spine, AB and lateral, and also do MRI spine,
Yes.
and taking good history.
How would you differ neurological deficit from vascular deficit? How would you confirm that?
Yes, vascular defects. There will be no numbness or weakness in the lower limb. There will be coldness, and it is vascular defects also increase as a pain increase by doing exercise, and there may be an ulcer, and maybe skin changes and ulcer. While neurological examination, there is numbness, diminished sensation or weakness, and it increased by exercise. That's all.
All right. If you'll do the ABPI of the patient.
What?
What ABPI?
ABPI.
Yeah. So if you do that, how would that tell you? How would that tell you, or how would that help you in confirming your diagnosis? If it's normal, then
yes,
what would you think?
Yes, if it's normal, it's around from 0.7 to 1.
Yes.
And if 0.5 to 0.7,
if it's normal, then it's neurological deficit.
Yes.
Yes. Then it's not vascular, right?
Okay, yes.
Yes. Okay, and treatment I didn't ask you, bell went, but if you can hurriedly tell me so we know that what management or treatment you can offer to this patient.
Yes, I will give the patient non-steroidal anti-inflammatory drugs, and referring for physiotherapy, and may also rest and ice, and avoid take precautions against avoid lifting heavy objects until we establish a diagnosis, and doing some minimal exercise. And if there is a decrease,
if conservative management fails, then
yes, if surgical, there may be a discectomy. I will do discectomy, yes, or
laminectomy.
Laminectomy.
All right. Okay. It was good. Some small things that you forgot. With the gait, I told you at that time, and then you'll also look for the walking aid crutches, etc. And when you're doing palpation for tenderness, you'll also look for the temperature. Rest of the things you've told me all correct. Sensations, you said pain and and light touch, and coordination, reflexes, tone. Just the femoral stretch test you forgot. And right in the beginning, patient will be there. So you give instruction. Once you have asked the patient to introduce or confirm the name and age, patient has done it. Then you'll give the instruction. Okay, take your pants off, keep the undergarments or whatever. Like you have to examine. So you have to give the instruction to the patient as well, what to do. And then you'll start your examination, right? So this is something you should not forget.
Okay.
Good. Yes, Dr. Jangir, thank you. Would you like to give feedback? Started your timer, and here is your question. Right. So if you're read and understood, considering its surgical and optimization, kindly identify what structure is this?
Inguinal
13.
ligament.
All right. Can you please tell me the attachment of the inguinal ligament?
Inguinal ligament is attached laterally to anterosuprailiac spine and medially to the pubic tubercle.
All right. Can you tell me what is the midpoint of the inguinal ligament? And the
Midpoint of inguinal
significance?
ligament.
Yes.
Midpoint of inguinal ligament is the midpoint of the attachment of inguinal ligament.
Okay.
That
How
is
is
from
it different from
anterosuprailiac
the
spine and
mid-inguinal
pubic
ligament?
tubercle.
Midpoint of inguinal ligament? Yes, please.
Midpoint of inguinal ligament is the midpoint of the attachment of inguinal ligament that extends from anterosuprailiac spine to pubic tubercle, and it corresponds to the femoral artery. And the midpoint of the mid-inguinal point is the point between the anterosuprailiac spine and the pubic symphysis, and it is related to the deep inguinal ring.
Can you please identify this structure?
The Sartorius.
All right. Can you please tell me the attachment of the Sartorius?
Sartorius is it originates from the anterosuprailiac spine, and it is inserted into the upper part of the medial surface of the tibia.
All right. Okay. Can you identify these structures from lateral to medial?
Lateral to medial is femoral nerve, vein, femoral nerve, artery, and vein.
Okay. Can you please tell me the boundaries of the femoral sheath or the femoral triangle? Make it more easy.
Femoral triangle, the base is bounded by inguinal ligament.
Yes.
And laterally by Sartorius and medially by adductor longus muscle.
Okay, what are the contents of the femoral triangle?
A femoral triangle from medial to lateral, a deep inguinal lymph nodes and lymphatics, then femoral vein, artery, and femoral nerve.
All right, okay. Can you please tell me, all right, can you please tell me the contents of the femoral canal?
Femoral canal contains mainly the loose connective tissue and lymphatics and some deep inguinal lymph nodes.
Can you please tell me one pathological and one physiological significance of femoral canal, please?
Pathological is it is a area of weakness for
yes.
femoral hernia.
Yes.
And physiological, I have no idea.
Okay, we'll get to know that. Can you identify the structures on the right-hand side diagram? This one, which vessel is this? Can you identify this structure?
Superficial femoral artery.
We'll find out. Okay, can you please tell me what is adductor canal and what are the boundaries?
Adductor canal is a space in the mid-thigh region, and the boundary is anterolaterally by vastus medialis, and anteromedially on the roof is formed by the sartorius, and posteriorly by the adductor longus and magnus muscle. And the contents are femoral vein, artery, saphenous nerve, and nerve to vastus medialis.
Why is it called adductor canal? Does it have any other name?
Yes, it has other names like subsartorial canal or the hunter's canal.
Yes. Why does it called this with this name? Okay. Can you please identify on the left-hand side all the structures in the image from A to D?
A to D. A is the common femoral artery. Then
B.
B is the profunda femoris.
C.
C is anterior tibial, D is posterior tibial, I think.
Okay, can you identify on the right hand side image? What kind of image is this?
It is the contrast contrast image of the lower limb arteries.
And what are you looking at?
And
if you can identify what is 1, what is 2, please, if you can identify.
One is the external iliac artery, 2 is the common femoral, 3 is the lateral circumflex, 4 is medial, 6 is profunda femoris, 7 is superficial femoral artery.
Okay.
And
what are the branches of the common femoral artery?
common femoral artery has mainly 2 branches, the superficial femoral artery and the profunda femoris.
Yes. Then
initially it has 3 branches, the superficial external pudendal, superficial circumflex iliac, and superficial external pudendal.
Okay, then where it
And,
divides and where it changes name? What's the continuation called?
The continuation is superficial femoral artery.
Okay.
And the branches is profunda femoris. It ends there.
Yes. Can you tell me the significance of iliotibial tract?
Iliotibial tract, it receives the insertion of gluteus maximus and also the gluteus maximus and
tensor fasciolata.
Tensor fasciolata, and the main significance is it helps in stabilizing the knee joint in extension and slight flexion, and it helps while walking and running.
Yes, good. All right. Can you also tell me what are the muscles of the gluteal region? How would you test Trendelenburg test? Trendelenburg. Yeah, test.
Gluteal region, there are mainly 3 muscles: the gluteal gluteus maximus, medius, and minimus.
Yes.
And the Trendelenburg test is done for superior gluteal artery, which supplies the gluteus medius muscle. And it is tested by asking the patient to walk, and there, if we see if we see the hip sags down,
yes,
hip sags down the contralateral part,
the healthy side. Okay,
healthy side,
can you
yes, normal
please
side.
tell me the surface marking of adductor hiatus? Last question, please.
Adductor hiatus,
it's a line along.
It's a line
between, yes,
between the
iliac spine
intersuperior spine and the adductor
tubercle of the femur. Very good. Last question. Okay, what is this called before we go ahead? This is aortogram, arteriogram.
Arteriogram.
Yes. So if what was 1? 1 is the catheter. See, so it is introduced in the right common femoral artery, and then 2 was the common femoral artery. 3 is the lateral circumflex femoral artery. 4 is the medial circumflex femoral. 5 is the perforating artery. It is 5, yes. 6 is the profunda femoris artery, and 7 is superficial femoral artery. It was very good, considering that this is the first time you are presenting. So yeah, this is which vessel is this? Because it says it's lateral, it's medial. So it should be easy for you now.
Looks like popliteal.
Yes, very good.
And B is
And then
posterior tibial, I think.
it's on
B is
the
posterior
medial
tibial.
side, so it's anterior tibial, and this is posterior tibial here, and this is peroneal artery. So very good. Okay. Here I did not see anything. Okay. You did tell me all that. Good.
About
Yes, and here is the question. Right, so if you have read and understood considering the critical care scenario, kindly tell me how would you manage this patient?
Yes, I will manage this patient according to the critical care of surgical inpatient protocol by maintaining patent airway, proper pacing, and adequate circulation. First, I will look for the airway and if it's patent or not, and then and look for the pre and assess the pacing. The patients here there is the
Yes,
yes
patient
there is
saturation has dropped, so
yes
yes,
so I will give the patient 100% of oxygen
yes,
and consider consider intubations. Then we'll look for the circulations. The patient has the patient's blood pressure is 70 over 40, so I will start giving IV fluid in the form of crystalloid, 2 liters, and
if you'll do the ECG, what do you expect to see? Because
for the
patient is
ECG,
having central chest pain, yes, and shortness of breath. You do ECG,
yes,
and this is something you caught. Can you read the ECG, please?
yes, the ECG, there is a positive lead 1 and the AVL, and negative lead 2 and AVF, denoting left axis deviation.
So what is your provisional diagnosis for this patient?
There is left ventricular hypertrophy.
Does that cause acute sudden chest pain?
Sudden chest pain, maybe.
Can you please tell me if a patient is diagnosed with aortic stenosis preoperative, then what is the pathophysiology behind that?
Yes, if the patient has as a pathology of aortic stenosis, there will be diminished cardiac output and increase increase the ventricular wall, causing ventricular hypertrophy and dilatation, and later on causing causing the diminished cardiac output and the heart failure.
How would the left ventricular endostolic volume or pressure will be affected? What will be the effects on
Left ventricular endodystolic?
pressure? Yes. LVEDP, how would that be affected? Would it increase or would it decrease? Because in aortic stenosis, cardiac output is fixed.
It will be decreased.
It will increase.
Increase.
Because the valves will be obstructed. aortic
Yes.
stenosis is happening, right?
Okay.
So, yes, can you define cardiac output, please?
Cardiac output, it is it equal heart rate multiplies the stroke volume. Yes, for that.
After ECG, what is the further imaging or further investigations that you can ask for this patient?
I will do 2D echocardiography
Yes.
and enzyme and the cardiac enzyme, ECG,
Yes.
troponin,
And transesophageal
and chest X-ray.
endocardiography. Okay. Do you
What?
think and transesophageal endocardiography? Okay. Can you please tell me if this patient should go ahead for the surgery or not? Because patient
No,
has elective to URBT, so you please justify.
no, the patient shouldn't go for surgery because he has because for the aortic stenosis, and it should be and it will be managed according to the size of aortic stenosis. Normal aortic diameter is from 2.5 to 3.5.
What are the
if
risks?
it
What are the risks if you operate the patient?
if I operate the patient, he
Yes.
has the patient
According to the NICE
I-
guidelines.
risks.
If you'll go ahead with the surgery, if you'll operate the patient according to the NICE guidelines, what are the risks that you should keep in your mind?
The risk is the patient may develop infective endocarditis
Very
on top
good.
of aortic stenosis.
So
Yes.
according to the guidelines,
should-
you have to give antibiotics.
Yes, I should give him antibiotic as he is a patient is on a risk of infective endocarditis.
Yes, and if you do not go ahead with the surgery, patient has carcinoma. So spread of carcinoma can
The patient
happen.
spread of cancer, yes, is a risk.
Bladder carcinoma, that has, okay. So what would you do first? Would you go for the bladder surgery or would you go for the valve surgery?
Yes, this depend on the valve diameter. The normal is 2.5 to 3.5
Yes,
centimeter. So if it is than 1 centimeter, so it is severe stenosis, and I should
Yes.
go for the for aortic repair first. However, open or endoscopy.
So what are the complications of aortic stenosis? What can happen if you do not operate on this patient?
Yes, there may be arrhythmia, ventricular tachycardia, ventricular fibrillation, and heart failure, and cardiomyopathy.
Yes. Okay. Who would you involve in the management of this patient?
Yes, I would involve the surgeon and the cardiothoracic surgeon and the general surgeon, or the urologic surgeon and the anesthetist and the ITU specialist.
Very good. Can you please count the heart rate of this patient looking at the ECG?
Yes, here is there is an equal RR interval, so I will count the number of R's of large square.
Yes.
Yes, it's 1 and 2 and 3 and 3.5. I will and divide 300 over 3.5, so it around 90 or 80.
Yes. Yes. Okay. Can you please tell me what is systolic ejection?
Systolic ejection.
Yes.
It is the maximum amount of blood that can be ejected from the ventricle during systole, and it is directly proportional to the amount of blood being ejected into the delivered during diastole.
Good. Okay.
According to the Starling law.
Very good. Very good. Okay. Why? Oh, okay. What leads to Bell has gone, but last question I'll ask you. What leads to syncope on exertion? And
What leads to syncope? The
Yes.
syncope?
Yes, how it happens
Uh,
when there is exertion.
because due to there is an ischemia to the brain, diminished blood flow. There is diminished the low cardiac output will affect the brain and neurological symptom and neurological system, causing confusion.
Good. Thank you. Yes, that's about it. I did ask you cardiac output and all the questions. Very good. Okay. Starting, and here is your question. So if you have read and understood, considering it history taking station, kindly begin.
Yes, good morning. I'm Mr. Ahmed, one of surgical doctors here. Can I confirm your name and age, please, ma'am?
Yes, I am Linda, 35 years old.
Nice to meet you, Linda. How can I help you today, please?
Yes, doctor, I have tummy pain here in my tummy.
I'm really sorry for that, but if you don't mind, can I ask you some question regarding your issue besides
Yes, please.
taking notes when I'm asking you? Okay.
Okay.
Please, before we start, are you in need for painkiller now to withstand the conversation?
No, it's okay.
Yeah. So, can you point to the site of the pain and where is the pain exactly, please?
Yes, right here.
The center in the upper abdomen, in the your upper part of your tummy. I'm
Yes, in
sorry.
the upper part here.
Okay. So, when did it start exactly, Linda? Please.
Yes, it started around 1 month ago.
Okay. Away from 1 month before that, have you had like this before?
No, it's coming and going, but it is more in since 1 day ago.
Okay. It started suddenly or gradually?
Yes, suddenly since 1 day.
Okay. So, can you tell me, please, it is specific to certain time along the day?
No, but I think when I usually drink vodka, and it may increase after drinking vodka.
Increase with vodka. Yeah. So, is there anything making it less or better?
Yes, maybe when I lean forward.
Lean forward. Okay. So, did it move anywhere else?
Yes, to my back.
Okay. So, it is specific to a specific type of food or movement?
No.
Okay. So, if you don't mind, can you rate out this pain out of 10, please?
Yes, 8.
8. Okay. So, now I will ask you some question, please. So, have you had any vomiting?
Yes,
So, how many times, please?
around 3 times.
Can you tell me the color of the vomitous, please?
No specific color, but there is no blood in it.
Yes, good, no blood. Okay. So, do you have any heart pain or tummy pain?
Yes, I have a tummy pain.
Heartburn or heart pain. I'm sorry. Heartburn or acid test in your throat.
No, no,
Okay, so have you noticed any change in the color of your eyes?
no,
So any change of the color of your skin?
no.
So
Yes, but
do you have,
no, just non-related. Okay, common look. Okay, sorry.
okay, have you been counseled for any cardiac problem or any chest problem issue? I'm sorry.
No,
So have you noticed any change in your weight, please?
no,
Any tummy swelling?
no,
Any change in your appetite?
no,
So have you been abroad recently?
no,
Okay, do you have any fever?
no. Actually,
So have you noticed that any change in your bowel habits? Any alternating diarrhea or constipation?
yes, but not to the extent that annoy me. Some
Yeah. Any
diarrhea.
any slime or mucus with the stool?
No,
Any blood in your stool?
no, no.
So have you noted that this pain is relieved by passing stool?
No,
So do you, I will ask you, what's your occupation, please?
working as a teacher.
Teacher. So please, I missed one thing. Have you noted that in your stool is difficult to be flushed in the toilet?
Yes,
Yeah. Okay. So with whom are you living in your home?
with my parents.
Yeah. Okay. So do you smoke?
No, actually,
So you told me that you drink vodka. How many you drink alcohol, please?
around half a bottle of vodka every day.
Okay. So any family member have had like this before?
No,
Okay. Do you have any medical condition?
yes, I am diabetic and it's well controlled.
Yeah. What do you take for diabetes as a medication?
Tablets.
Tablets. Okay. Have you had any surgery before?
No,
Okay. So what do you think is the cause of this issue?
Okay, can
maybe
you
it's
present that?
related to diabetes.
Yeah. So what do you what do you hope us to do for you?
Yes, to relieve this pain.
Can you present the
Yeah.
case now?
What?
Can you present your case now? Bell has gone.
Yes. Thank you for your time, Miss Linda. I will pass my notes to my consultant to figure out your issue. Miss Linda attended today complaining of sudden abdominal pain that presented suddenly 1 month ago, exacerbated in the last 24 hours with 3 episodes of vomiting.
Yes.
It is in the upper abdomen, referred to the back, relieved on leaning forward, increased with drinking vodka. She is alcohol drinker.
Yes.
It's about 8 out of 10 according to the severity. Associated with vomiting with no history suggestive of cholecystitis or peptic ulcer disease, with no hematemesis, with no relation of the change of bowel habits or skin changes, referred to the right shoulder. She is alcohol drinker
So what are your
and no
differential
significant
diagnosis?
weight loss or
Yes.
appetite. So my top differential diagnosis is acute exacerbation on top of pancreatitis, on top of chronic, as
Yes.
the patient is alcohol drinker and
Yes.
with recurrent attack of this, but I will
Yes.
consider other causes for this complaint in
Like?
form of yes, chronic calcocystititis, peptic ulcer disease, or pseudopancreatic cyst leading
Yes.
to dyspepsia,
All right.
and also gastroenteritis, but it is not eligible here.
All right. What management do you suggest for her?
Yes, as regards this patient as alcohol drinker, so I will start to treat the addiction for the alcohol drinker according to psychology and the addiction team. I will control also the patient is diabetic, so I will control diabetes by proper management, including the endocrinologist. I will also adjust the diet, decrease the fat, and proper dietitian with diet team, carbohydrate and proteins. Give
Yes.
painkiller according to WHO step ladder analgesia, and I will adjust the dose of morphine that the patient is taking.
Yes.
I will give the patient also replacement enzymes um, for pancreatic enzymes, and search for any obstructing lesion or either in the duodenum or the CBD, and give the patient antibiotic and the proton pump inhibitor, and follow up the case of the parameters of pancreatitis, and also will order CT to detect any obstructed lesion or MRCP, any obstructed lesion or chronic pancreatitis calcification.
Very good. Okay. Thank you.
Thank you.
Yes, it was good. We covered everything. So, any feedback you want to give, Dr. Hamdi? Anything you feel?
No, I covered it.
Yes, you nailed it. Actually, that's good. Thank you.